Welcome, everyone, to the Body Pod. I am so honored to have our special guest today, Dr. Rocio Salas-Whalen, who is a triple board certified endocrinologist and obesity specialist practicing in New York City. So, welcome, Dr. Whalen.
Thank you so much. I'm so happy and excited to be here with both of you.
Oh, we're so excited.
We we are so excited, and you're on vacation. Are you on vacation or are you
I'm on spring break with
working?
my kids. This
She
is
just showed us the view, and Haley and I are so envious that we're not there doing it live.
Oh,
thank
I know.
you.
I'm so mad. I'm gonna come see you in New York, though. I'm gonna take you to lunch when I'm there
Yes,
next. I was
please,
just there.
please, please, please let me know when you're in the city.
Yes, let's go at the same
Yes.
time, Hale.
Oh, I just was there a week ago. Yeah, a week and a half ago. So, anyways, next time I'm there, I'm gonna hit you up. But anyhow, welcome, welcome, welcome.
Thank you.
We have so many questions to cover. So today, everyone, we are talking about all things semaglutide and the obesity epidemic that we are facing. So Dr. Whalen is one of the top, if not, I would say the top in her field,
Thank you.
definitely for me, that owns a practice in New York City. So I'm just curious, can you just give us a little background about how long you've been practicing, what made you get into this specific area? I'm so curious about that.
Yeah, so I've been practicing since 2010 when I finished my specialty. And, you know, 14 years ago, we didn't treat obesity, or we didn't talk about obesity as we talk about it now. In fact, we didn't have a specialty back then in obesity,
Mhm.
right? It was endocrinology, and that's the reason that I went in endocrinology, was to work on metabolism. I was always interested in type 2 diabetes and its relationship with weight, right? And how
Mm.
if you control one, you would control the other one. Um, and then obesity, then we started having medications for weight loss, and I think that opened a huge Pandora box, right? That for the
Mhm.
first time we could offer patients something that actually worked. And
Yes.
then it just, my path became more obesity and weight loss, and not so much type 2 diabetes.
Mhm. Oh, well, I wanna start with this staggering statistic that I heard you say, that by the year 2030, the World Health Organization estimates that 50% of the world population will have obesity.
Yes.
I mean, that is, like,
So scary.
so
Yeah.
It
terrifying
is. It is.
that we have.
And including children, right? I mean, I
Oh,
think that's the biggest difference in future statistics, is that it includes children. um, and those children will become adults with obesity, right? So we're not just
yes.
talking in the next 7 years, we're talking in this next decades, right, of years. But
Do you do you think that America is America the worst?
America's not the worst. The worst is the Middle East right now,
Mm,
in certain countries in Latin America. Mexico, unfortunately, is also very top. But definitely the United States is, I believe, is number three or number fourth in regards of world obesity, which is
Mm.
pretty high.
wow.
And obesity
So
is, do you find it's growing because of food quality or habit? And obesity is a disease. So some people technically are born with it also, correct?
Yes. So there's a lot of recent published papers showing that prenatal mother's weight impacts the weight of the offspring in the future, right? So even your weight preconception is going to impact the future of your future children. So we're going even back
Mm,
then, right? And then we live in a very industrialized world. We live that we call obesogenic environments, right? Everything in our life, from food industry, the chemicals, working from home, promote obesity, right? Or make it
mhm.
difficult for people to lose weight. So if you think about it, I feel like we're set for failure, right?
Yeah.
Mhm.
It's a very difficult fight to win against everything else that is promoting weight gain and obesity. It's becoming part of our genes, literally.
Oh, this is okay, and I think that a lot of it has to do with, I mean, you're in New York City. I lived in New York City for a hot minute. But when people can feed their family at Taco Bell for $25, I mean, I know New York City has made, like, the fruit stands outside of the actual, grocery stores, you can get decent, really good pricing on that, but, I mean, some places in the Southeast, I mean, there's just a lot, like, it's easier to feed your family at McDonald's. I mean, that's a problem.
And I mean, New York City is changing. I remember when I moved to New York City, uh, you could see you didn't see so much obesity. It wasn't there. But now there
Mhm.
are Taco Bells next to the subway station. There's Dunkin' Donuts. There's Chick-fil-A. There's McDonald's. There's Krispy Kreme. And they become so popular that even there's lines outside those restaurants, right? So even New York City is different now. There you can see how much more in regards to obesity has changed New York City. And
Yeah.
we're a city that we walk and we take the stairs and we take the subway, but even with that, the food industry, it's really
Mhm.
really making it very difficult.
Yes.
Yeah, we're having to overcome the food industry. But yeah, convenience and the quality of food is
And
such a
price,
huge issue. Yeah,
right?
and price,
And
huge
price,
issue.
unfortunately, you cannot
Mm.
ask a family, a single mother that is working two jobs and has two, three kids to buy organic and buy uh,
Yeah.
everything clean. And I mean, it's expensive.
So this is really interesting because I run like fat loss courses throughout the year, and it really is just it's an education course. I mean, we walk everyone through it, but it's just like giving all, like, taking out all the BS of, everyone that's like, do this, eat this, don't eat this, and just really being like, this is what the evidence says, in this area, and we cover that. But I can't tell you how many women come in and they're like, I'm really not eating that bad, and I just keep like, packing on the weight, and it's so hard because the food industry, as you said, I mean, it's like, it's made to taste good,
Yeah.
and all of these processed foods, like, where we actually don't get full on them, and the brain doesn't get the message to stop eating and all of that. I mean, it's just fascinating because women come to me all the time. They're like, I'm just like, I'm done. I'm done. Like, I really, I'm exercising, I'm doing this. And that's what's hard is you just, a lot of it is we don't know the calorie content in our foods as well. And we go to, I mean, if you're eating at these restaurants or fast food places that I call America the land of convenience, that are just anywhere you go, it's really hard to be like, well, I'm really not eating that much, but what consists in those calories? And,
And the quality.
and yes, well, and I think the stigma that obesity is strictly like, well, you just need to have more willpower. I mean, like, no, that's not it.
I see that. I'm talking about the food industry. Like I have a lot of patients that are from different countries. They're coming from Europe, they're coming
Mhm.
from Asia, they're coming from, and they all have the same story. They all gain 20, 30 pounds when they move to America, to the United States.
It's
Yes.
not
I
surprising
mean,
at
it's
all.
every single patient that I see, like in that immigrated here, is the same story. They gain
Yes.
20, 30, 40 pounds of
Mhm.
weight, right? And yes, I mean, we know now that obesity is a chronic multifactorial disease, right? So it's not a problem of willpower. Um,
Mhm.
I do think that the food industry one day will become accountable for
Yeah.
producing the statistics that we have in obesity worldwide, right? Like
Mhm.
this, like the tobacco industry at one point. I feel like
Yeah.
it
Yep.
was going to be the same. Hopefully, one day it will be because we talk about many solutions, right? And including weight loss medications, but really, the main solution is changing what we eat, right? That's a
Yes.
huge part, and we have little control, but we haven't lost all control. I always tell
Mhm.
education is going to be our biggest weapon against the food industry, right? Because the
Mhm.
less we know, the more they can control what we eat. The more we know, the more we can somehow control what food choices we make. So we still have some control on it.
Mhm.
So if I'm a client of yours, and for example, what you just said, if I'm a patient, I come to you, I'm 30, 60 pounds overweight. How do you address, and I know everyone is different, and
Mhm.
but what are the things before, Ozempic and all of the medications in that family, or before you treat them with that? What do you do to address the situation besides what you just said, educating them?
So first, I take a very thorough family history, right? I ask all of my patients the same question. At what age were you conscious about your weight? Or at what
Mhm.
age were you being careful of what you ate, right? At what age did you stop being unconscious about how you look or your weight? And the majority have the same 9 years old, 8 years old.
Oh.
So young, that's
So
heartbreaking.
some tell me I was put on my first diet at 9. I had my first personal trainer at 12. I was sent to fat camps since 12. So I just want to see how far back in the patient's history was this something of an issue, right?
Mhm.
Because then that tells
Mhm.
me how complex the disease is, how complex the obesity is, and how little or not is lifestyle involved in this patient's life, right? Um, so it's doing that, doing a family tree, right? I want to know what's the weight history of the mom, the dad, the siblings, even the grandparents, the uncles, just to see where is this coming from. And I would say in 70-80% of my patients, there's always some family inheritance of obesity.
So it's
uh,
like 70
Mm.
to 80%, it is kind of a
it
genetic
is kind.
credit.
There is either coming from the father or the mother side, and there's impacting their weight,
Okay.
or that there's a history of struggling of weight in one side of the family, or sometimes in both families, right? Then
Okay.
definitely medication list. I mean, there's some medications that can promote weight gain, antidepressants, blood pressure medications.
Mhm.
Mhm.
Some anti-diabetic medications like insulin can promote weight gain too. Um, and then going into their lifestyle, their work, their sleep patterns, right? Exercise. What are they exercising? What normally they eat? I tell them, tell me what you ate for breakfast yesterday, lunch, and dinner. I just want to get a
Mhm.
sense of really deep dive deep into the patient's life, and where
Mhm.
can there be tweaks, if any. But
Mhm.
for the majority of
Mhm.
patients, it's something very humbling that I learned through practicing obesity medicine, is that the majority of patients with obesity or struggling with weight, they're doing everything they can,
Mm.
right? They're
Yes.
exercising, they're eating healthy, they've tried hundreds of diets. I mean, it's
They've been
it's
on a diet since they're 9.
it, it's really sad, and it when you hear somebody's, even from childhood, weight and their eating and their food in front of them, it's 24/7 a full-time job, right?
Yes.
It's everything
Yeah.
that is in front of them. How is this going to impact my weight? Am I going to feel guilty after I eat it? Am I not going to feel guilty? Or how can I compensate? And it becomes a mental health draining, right, from their
Yeah.
weight. So it's really unfair, and I always try to speak this very out loud, is that we had it wrong. Patients are not the couch potato that we're thinking, and that we had
Yeah.
the idea that they're just eating, they don't care, and they're just gaining weight. It's quite the opposite. Patients with obesity know they have obesity. They want to lose weight. They're trying to lose weight, but it's just not happening.
I remember I reposted something that you had, like, something on your Instagram months ago that said, "Imagine the noise that's constantly going on in their head What am I going to eat? What is it going to do to me? How is it going to impact my weight? Constant noise. It's
Every
exhausting to think about.
day,
And
every day.
It's all
yes.
consuming, which then affects how you show up every day, your mental health.
Mental health, your
Yeah.
mental space,
Mm,
the mental space that this occupies in people with obesity or overweight or struggling with weight is it's a huge part of their mental space that you can think what would happen if we take that out, right?
Yeah.
mhm,
What are the possibilities to occupy that other mental space that is being occupied by the constant thinking of their weight and food?
mhm.
And it's
Yeah.
something that we don't
Well,
realize because in medicine as doctors we learn about the pathology, like the doctor side or what we can do, but we never learn about what the
mhm,
patient is going through, right? We
mhm,
don't hear those stories that hear
mm.
every day in my clinic, right? Is that it makes you think like, wow, we've been telling patients go eat less, exercise more, and that's all they've been doing all this time.
Ugh.
Well, there's another, I messaged you a few months ago when I was doing a podcast with, I don't know if you're familiar with Dr. Bill Campbell, but he's in the fitness world, and he, was just doing, like, the research on Ozempic and semaglutide and all that. Like, that was just the purpose of, like, here's all of the current research that we have. And so I reached out to you because, I mean, when I put it on, I was like, "Holy cow, this is a polarizing topic," because people were like, "How they're taking it away from type 2 diabetes," and just freaking out. I was like, "I'm the journalist here, like, I'm not the one taking it away." But I remember I reached out and I was like, what's your view on this?" And you said that, there's 72 million people that were obese a few months ago versus 41 million people with type 2 diabetes. So it comes down to, can you explain that? Because I was just like, "Oh, this is it right here."
So this medication, this class of drugs with our incretins, GLP-1s, they were designed for type 2 diabetes. And it's
Mhm.
a really, I like the story of how it was discovered. It was in 1994 by an endocrinologist and researcher at the VA hospital in the Bronx in New York, Dr. John Eng. And he was
Oh.
studying the Gila monsters, which are lizards from the southwest.
Mhm.
And the Gila monster in its prey, they kill its prey, causing pancreatitis. So Dr. Ang wanted to know what in the venom of the Gila monster causes pancreatitis. What effect does it have in the pancreas? And that's how
Yeah.
he isolated the first GLP-1 called exenatide back in 1994. So thanks to him, we have
Wow.
this revolution of the GLP-1s. And then in 2005 was the first FDA approved GLP-1 made from exenatide, what he had isolated from the Gila monster, and it was named Bayera. And that was a daily injection before breakfast, 30 minutes before breakfast and 30 minutes before dinner. And then after that, Bayera came Victoza, which was once a day injection. And then 2017, Ozempic or semaglutide, which is a once a week injection. But when in 2010, when I started practicing Victoza, which is liraglutide, also for Novo Nordisk, was FDA approved for type 2 diabetes. And I remember started using it in my patients, and they were coming back with better glucose control and weight loss, which was the first time that we were seeing that in a medication, because most medications for diabetes promote weight gain, actually.
Yeah.
But this drug only acts in your pancreas if your sugar is elevated. So you actually have to have diabetes to work as an anti-diabetic drug, meaning they don't cause hypoglycemia on somebody who doesn't have diabetes, like insulin, right? If you give insulin to
Yeah.
somebody who doesn't have diabetes, the sugar is going to drop and they can die. But
Mhm.
incretins, GLP-1, your sugar is normal. It's not going to touch the pancreas. It's just going to pass it next to it. But then we get the benefits of the weight loss, and that's when we started using it off label, including myself back in 2010, for weight loss independent of type 2 diabetes. And then in 2012, it was FDA approved for weight loss. So these medications have the FDA approval for weight loss since 2012,
So it
right?
really isn't just for diabetes.
Is not only for type 2 diabetes. We have clear FDA guidelines for weight loss independent of diabetes. What they did, the pharmaceuticals, they changed the name Victoza to Saxenda, Ozempic to Wegovy, and now Mounjaro to Zepbound. Same drug, same molecule, same pharmaceutical, same dosing, same pen, just different names for different
Wow.
indications.
Oh, that's so interesting. So, okay, with when people are looking at this, I think, I mean, I'm in the, personal training fitness world, but when I have clients come to me, they're like, well, I kind of am interested in this, but I don't want to have another fen of the 90s where people are really freaked that there's going to be all of these, side effects that come out in 10, 20, 30 years.
Yeah.
Do you think that there are some,
Mhm.
or what do you think of the side
So,
effects,
I
Short
mean,
term
if
and
any?
long term.
yeah, going back to what I just mentioned, I mean, we have close to 30 years of data on this class of drugs, right? Uh,
Yeah.
the newer versions are newer generations, but with the same concept back in 1994, right? So we
Mm,
have enough data on these drugs to know its safety.
mhm.
Uh,
Yeah.
Now, I say this, and I said it multiple times, and I say it to all my patients: the safety of these drugs, and even the effectiveness, the benefits of it, will depend on how much expertise who's giving you this drug on them have, right? If I
Yes.
start prescribing medications that I don't have much experience, just because I'm a doctor, I can prescribe chemo drugs, I'm going to create more harm than actual benefits. So, those side effects that we're seeing now that they were not reported in all the control studies are being
Mm,
caused by providers that don't have experience on this medication, right? That don't know how to uh, lead the patient's journey with this drug, because every patient is different. What may work for one may not work for the other one. So every treatment should be very individualized to their lifestyle, to their necessities, to their weight, to their other medications that they're taking. But when you don't do that, then you run the risk of creating side effects that were not expected, that were not seen in the control studies. Patients that are not being followed properly, right? Uh, Patients that are not guided the right way. And then sometimes we have patients that want to get results too fast, and they may overrun our recommendations. Then we're going to see other side effects, right? So I feel like all those side effects that we're seeing are really caused by improper use of the medication.
That makes sense.
Even, and this is
yeah.
talking long term and short term side effects, right?
And if people that are obese, there are so many risks and problems, that health issues that come from that. And a lot of people I know that have gone on the medication and have lost a lot of weight, they actually are so much healthier now, and health issues they were having are now they aren't a concern anymore. So it seems that the benefits far outweigh anything than not taking it, right?
Definitely. So we know there's more than 16 cancers related to obesity. Even now, we're seeing more breast cancer related to obesity than genetics, right? Colon cancer, stomach cancer, thyroid cancer, pancreatic cancer. We see more of that with obesity than from the medications that we're hearing that, right? Um, these medications really are going to change the way that we practice medicine, because I feel like in the next 2, 3 generations, we're going to have less chronic diseases, much less type 2 diabetes, different types of cancers related to obesity. So, really, we are exchanging one drug for a long list of other medications or other health problems.
Do you think that this
Okay.
drug class will help the obesity epidemic? Do you think that it could actually really drop the numbers and make a change in this world?
I think that prediction of the WHO, that 2030, I feel like that is going to be less,
Mhm.
thanks to
Yeah.
our current treatment that we have for obesity.
Mm.
It's so interesting. I mean, coming from the fitness world, I know that I've been on a lot of like in groups where we're discussing this because it's changing the fitness world. Absolutely. People are getting more comfortable to come into the gym, making a lot of changes. And there's of course pros and cons on both sides of the issue. But the con side would be trainers that are like, well, now everyone's just taking it. It's super easy. And they're not actually learning the proper education and the psychological component. But I'm going to guess that this is where you're going to say, well, it comes down to the provider. If someone at the next to the Walmart is, you know, prescribing this drug that has no experience just for the sake of financial gain, then that's not helping either. What's your opinion on that?
Definitely. I think in regards to the fitness world, I see something happening in my practice, and I foresee that this is what's going to happen, is that people are going to start exercising for health
Yes.
and not for weight loss. I think that
Yes. Oh,
I feel like that's huge, and it makes me so happy when I see patients. I started going to the gym. I Because one thing, I mean, you're more self-confident, number one, when patients start losing weight. You're more
mhm.
flexible, you're more movable, you're not short of breath. You physically can perform better, right? And then
Yeah.
patients, it's very amazing to see the journey of patients. They come with a concept of wanting something external, right? To
Mhm.
look certain way, to feel certain way, and then halfway of the journey, because I always talk about muscle protein, it flips. They start to feel healthy, they start to feel strong, and it becomes a fitness journey and not a weight loss journey anymore. So
Oh,
more than ever, I feel people are start going to embracing exercising for the right reason and not for the weight
Yeah.
loss, right? Because for the weight loss, you always see it as something temporary, as a punishment. But when you're
Yeah.
exercising because you feel better, you want to extend your longevity, you want to feel healthy, then you adapt it. It becomes part of your
Mhm.
life. So I think it's a
Yeah.
very positive shift that you trainers are going to see people coming in for the right reasons, and not that everybody doesn't, but the majority of mentality is exercise to lose weight because that's what we were
Yep.
teaching before. uh, that's
Yeah.
changing, and more than ever I feel
Mhm.
like the medical community and the personal trainer business, we have to be more in
Aligned.
alliance
yeah.
than before,
Mhm.
because together we're going to make the patient healthy and fit, right? More
Yeah.
than ever, I've never recommended to my patients to go to the gym or personal trainers as much as I'm doing every day now.
Yeah.
I love that.
Well, I do have to say, I have women coming into my courses all the time, either one-on-one or in these groups that I run multiple times a year. And when I'm running the numbers, like I always like there's always a couple of obese people that come into the group. And emotionally, I am like, I don't want this to be another source of failure for them. Because so this it totally, I mean, from my point of view, when I've been on these, panels, I'm like, this only helps us because it's giving someone that they're like, okay, well, I don't have as much noise in my head. I'm seeing some change. So now I can take on this education component, or, and the behavior change and habit change and all of those things that are needed when someone starts to wean off of the drug. Do you recommend, I mean, I know this is still fairly new and this may change. Do you have like, can somebody be on this for the rest of their life? Or is the goal to get them to a place where you're like, okay, we're going to wean you off, but the habits, the behaviors, the education has to be there as well?
So if we go back to what obesity is, that it's a chronic disease, and chronic diseases we don't cure, right? We control.
Mm,
So the idea with these medications is that they're designed for long-term use. And
mm,
one, I think we should shift it as a positive thing and not as a negative thing. because for the
Mhm.
first time we have something that's going to help you maintain the weight loss, right? Because many
Yes.
things can probably take you there, restrictive diets,
Mhm.
but the moment that you stop or that you're left on your own is when the weight regain happens. So with these medications, we can not only take you to your goal, but we can help you keep you on your goal. They're safe to be
Yeah.
used long term if we're talking about safety. Now, uh, weight loss medicine is very new, and a lot of things are changing, and we're learning as we're doing. And if I can talk about my personal experience with my patients, those patients that are able to maintain their muscle mass, those patients that are able to gain muscle mass, have more a probability to maintaining the weight loss at the lowest dose possible or with maybe no medication, right?
Wow.
Because whenever you hear, oh, losing weight slows down your metabolism, the reason for that is because you lose muscle with weight loss, right? With any, and
Yeah.
this is not exclusive to semaglutide, this is not exclusive to any of the
Yeah.
drugs that we're talking, this is just exclusive of dieting. uh,
Mhm.
Patients lose muscle. Muscle is our most, and you know this, muscle is our most metabolic organ, right? It's our burning
Yeah.
machine, it's our burning calorie machine. So if you lose it while you're losing weight, that's what's slowing down your metabolism. But if when
Yeah.
you're losing the body fat, you're maintaining your muscle or even gaining muscle, that becomes part of the maintenance for the weight loss.
Yes. And I think it's interesting too that a a lot of, young trainers or just people not even in the profession think that it's shocking to think that, like, someone who is obese, they carry a lot of muscle mass. They also carry a lot of fat mass, but it's assumed that they just don't have a lot of muscle mass, and that's not the case.
Well, it's
I mean,
interesting
o
because research has shown that yes, people with obesity have more muscle mass, but it's not healthy, all healthy muscle mass, because
Mm,
there is fat in between the muscle
mm,
fibers.
okay.
So it's not necessarily that their metabolism is higher because they have so much muscle. Their muscle is not the same when it's lean muscle.
mm,
Okay.
that's the ticket right
Exactly.
there.
So when you're on this medication, it really is way more beneficial to strength train and work out while you take this medication. Yeah.
100%. So, and it's strength training, what I recommend, right? Resistance training, strength training. It's important for many patients. It will take time. It will take 20, 30 pounds of weight loss
Mhm.
before they feel motivated, physically and mentally motivated to go to
Yeah.
exercise, right? But
Mm,
I always have that the initial consult is always half of it is going to be exercise and protein.
mhm,
Exercise and protein or exercise and diet doesn't replace the medications. The
Yep.
medications
yeah,
don't replace exercise and dieting. It's
hand in
50-50.
hand.
Yeah. You need
Mm,
all of the components. Okay, so what about people that are taking it that aren't obese, but they just have that like 10 to 15 pounds and they just want to do it short term and take it? Like patients that come to you. I mean, do you have any patients like that?
Yes. And it's easy to say when somebody, oh, it's only 10 or only 15, only 20 pounds that I may have to lose. And whenever I do a body composition, it turns out that they have really high visceral fat or
Yeah,
they have more than 10 pounds to lose, right?
right.
Uh, so it's if we go by the number in the scale or we go by the BMI, I think we are under treating many patients that should be treated, right? So I feel like it's not fair to say this patient doesn't need it just by looking at them without knowing their body composition, right? And then for
mhm,
those patients that are doing what they should and they still cannot lose those 20 pounds, then I dig more deeper into how much is this consuming your life, right? How much
mhm,
is this take over your day? And for some patients, it becomes, again, a 24/7 to lose 20, 30 pounds or 10, 15 pounds. Then those patients, if they didn't do what they were doing, probably they will need more pounds to lose. So those patients would benefit from the medication, right? Because
Absolutely.
they're being consumed by that. And if we put there perimenopause, menopause, then it's going to be classic that they're doing what they were doing at their 30s, early 40s, and it's not happening, and they keep gaining weight, and it's because of those change of
Mhm.
hormones, right?
Yeah.
Yeah, which brings me to my
I know.
next
I was
topic
like, this
of
is the next big topic that Haley and I love to talk about.
the hormone replacement therapy, the Ozempic study that just came out, which I haven't had time to read because I just launched a course a few days ago, and I'm like buried, but I've seen you talk about it
Yeah.
already and I've seen it on social media. So, can we talk about that weight loss response in regards with into hormone replacement therapy?
So in this study, it showed that women that were on HRT, on hormone replacement therapy, and semaglutide versus the ones that were just on HRT, they lost more than 30% more weight loss than the ones that was not on semaglutide with HRT.
Mm,
It's a very small study, right? I feel like before we jump the gun into saying that HRT helps with weight loss, what it does, it changes your body composition. When we lose estrogen, the body fat that was in our fertile years, in our hip, in our legs, goes intravisceral, so in our midline, right?
mhm.
When we give back the estrogen, there is again that change in body composition. We lose visceral fat, it goes more into our fertile years areas, but it doesn't cause weight loss. It just changes the body redistribution. Now, we know that with perimenopause and menopause, especially with the hot flashes, the lack of sleep, that demotivates a woman to exercise, right?
Yeah.
Because you're tired, you're not sleeping well, you have the hot flashes. So they didn't look that in the study if their lifestyle changed it, that they were more prone to follow a healthy lifestyle just from the decrease of some of the perimenopausal symptoms, including depression, mental health, change in mood. So it's not the
Yeah.
actual hormone replacement therapy causing the weight loss. It's we don't know if there were other factors involved because I didn't check them.
Well, I just love that there's a study on this early with menopausal
Yeah.
women because as you know, and I know, and like it's just we always get the shaft in this age group. It's like, "Oh, well, you know."
But I always tell my friends and patients, I said, this is, we're living in the right time to be this age,
I could
Yes.
not agree more. That was
because
one of my fears in going
things
through menopause.
are changing, and I'm so happy and I'm so excited for women and for myself and for my daughters, because we
Yes.
have, once we're accepting more hormone replacement therapy, we know it's safe, we know the
Yeah.
short-term benefits and the long-term benefits, right?
Mhm.
And now we have medications that can help us with weight loss that, for whatever reason, it cannot happen on its own. So
Yeah.
we are building superwoman, superhuman. And I feel
I
like
love it.
it's well deserved. We waited for a long time. No more mental
Yeah.
health, no more putting on antidepressants, no more getting the short stick of the end. It's just no more gaslighting of our
Mm.
symptoms, basically.
Yes.
Amen.
One amen.
I know I've been terrified to go through menopause, and because I thought my biggest fear was I'm not going to have control of my body, because that's kind of what the conversation always leads to. All of a sudden I've gained weight, I'm exhausted, the hormones, all of the things. And like now we have all these tools. We have hormone replacement, this medication, everything else. And it doesn't scare me, which feels empowering.
100%. And the best anti-aging is muscle, right? So
Oh,
we also have this concept now. We're accepting this concept that not more exercising just to lose weight, but for
Yeah.
longevity and
yes.
anti-aging. So we're packed with our hormones, our semaglutide, and our weightlifting. We have all the tools
And our protein.
Yes.
for a long, healthy, high quality of life.
Yeah. Oh,
I
I'm
have
s
the full body chills. I'm so,
me too.
It's
That was like perfection. I that needs to be like on a
I
billboard or
know.
something. That was
T-shirt.
it.
Let's make it a t-shirt. No, it's just, it's like I feel like we women, like we get asked for so much and we have so much pressure that even like midlife is like, okay, now how are you gonna what are you gonna do now new, right? Like you have to reinvent yourself. And
Yeah.
it's like, no, we've done enough. I feel
Yeah.
like also we should see it as a just a continuation of our life. It doesn't have to be
Mhm.
this big change that, oh, what are we going to do now? Just
For
continue
sure.
being as fabulous as you were before going through
Yeah.
menopause. It's just a continuation of our mental life, our
Hmm.
sex life, which I think it's
Yes.
very important. And I feel like many women let it go and give up after children or after 40 or after 50. It's like, we don't deserve a sex life. We had enough. We had our kids. No, we
Yeah.
deserve a healthy, satisfying sexual life, physical life. So we have the tools.
I appreciate you saying all of that. I that speaks volumes to me. I feel like it's important.
So what are the drugs that are there any drugs coming up? I remember you saying something like this and it piqued my interest a few months ago about a new drug coming out. Maybe it's out already. I'm not sure the timeline. It was probably 6 months ago that there's a new drug that can help hold on to muscle mass. Like how is that?
So
What is that?
this what we're seeing right now in semaglutide Ozempic is the tip, right? It's just it's the beginning of very sophisticated drugs that are coming our way. One of them is one that promotes the weight loss, that has the GLP part, and it has a medication that will help prevent muscle loss and help muscle gain in the drug, right?
I'm
What?
like, sign me up for that. Is there a trial?
So there's again the drugs are gonna become very sophisticated in the future. This is just the beginning. I mean, this what we're seeing now is probably the biggest event in medicine that we're gonna see in our lifetime happening.
So exciting.
Oh, so what is your professional opinion then about if there is a drug that can hang on to muscle or even grow muscle, why would somebody need to eat a lot of protein and weight train?
Because you
What
need protein, you need the amino acids to build muscle, right? That is not sustainable. I mean, nutrition, I don't think there will be a point that will be replaceable by a drug, right?
Yeah.
Mhm.
We need food, and our muscles need amino acids, right, to build muscle. So you can have a protein or a medication that prevents muscle loss, but you still need the basis to promote muscle gain and to maintain the muscle,
Mhm.
right?
Well, and movement
I'm
is
trying to
medicine.
foresee the
Yeah.
questions that will come up.
Yeah,
Right.
no, and again, this is not out yet. And even when a medication comes out, you have to realize those are control studies of 1,000, 2,000, 3,000. But once it's out in the public, then we learn more
Mhm.
about them, right? And what is still needed
Yeah.
or not needed. Like Ozempic,
Mm.
these medications in the studies, they never did body compositions. So they didn't know that there was muscle loss
Um,
Oh,
okay.
until now. We're doing it and we're doing body compositions on everybody, and we're like, oh,
yeah.
they lost 30 pounds but 10 were muscle. So we're
Yeah.
fixing that. So the same way is going to be
Mm.
with the future drugs.
So, if somebody comes into you I think this is the other issue. How? Because it can be like $500, $700 a month. Does insurance cover it for everyone, or is it still hit and miss?
Insurance is the rock of every doctor in the shoe.
I
Yes.
bet.
How is it this crazy in America? Like, can
Still,
we not fix it?
still, when there was shortage of the medication, oh, I see all my, like, my assistants in my office, I call it the Hunger Games. It was like getting, see who had the pharmacy, had it or not. It's and the insurance who would approve it. Right now, there's guidelines that the insurances go by, and it's the guidelines that were done by the Obesity Society and the Obesity Medical Association, where they state that BMI equal or greater to 27 with one comorbidity, and this could be sleep apnea, osteoarthritis, high cholesterol, are approved
Mm,
are for weight loss medication or a
wow.
BMI equal or greater than 30 without any comorbidity. They meet the qualifications for a weight loss medications, right?
Okay.
So you have a patient that may meet the qualifications, but then the insurance may not have it on their plan, right? So
Mm,
it's not just that you meet the qualifications that the insurance requires, but also that they actually have it in their plan. And some insurances have what they call exclusions, and those are never approved, even that you meet the qualifications. And because these medications are relatively expensive, so most insurances don't have them in their formulary. Now, if you're going to pay out
mm,
of pocket of with the medication, then we're bypassing the insurance, right? But there are expensive medications. But my question is, how much money do people spend on all the other diets, right? That they go
yeah,
through, um, thousands through their lifetime.
yeah,
And how much is your health worth to you, in my opinion? I mean, if someone said, I mean, I don't know the cost of all of them, but I don't know. I would say that your health should be the number one most important thing that you're spending your money and time on.
Yeah, and for out of pocket, both pharmaceuticals right now that have coupons. If you have a commercial insurance and you're out of pocket, meaning that the insurance is not covering it, they have a coupon and it comes out to about $500 a month. Either
Mhm.
Ozempic, Wegovy, Monjaro, or Zepbound, they're more likely around the same price. If you
mm.
don't
Well,
have
that's good to know.
insurance, and then it's about $1,100 a month.
Yeah,
Oh
that's a
my
lot.
It's a
gosh.
lot.
Yeah, that is a lot.
But how scary is it to take something like, you know, a lot of the Americans, I'm not gonna say that I've never done it, go to Mexico and get like a sleep drug or something. Like, how dangerous would it be for I'm sure there's 9,000,000 places that you can get it, but like you said, it's not through a physician, it's not managed. I mean, I'm sure those
Well,
can be
just for
dangerous.
you to know, it's unfortunately in the US how the prices of the medications are ridiculously high. These drugs,
Yeah.
Ozempic, in a pharmacy here in the United States out of pocket is going to be $1,100 for a month supply. If you go anywhere else outside, not just Mexico, if you go to the Middle East, in Europe, and in Latin America, it's about $200 a month.
Oh my god,
What? Okay, so it is the same though.
It is the same.
It's not like
It's
sketchy.
approved. Yeah, no, it's not
it's the
sketchy.
same.
It's the same.
This makes me so mad,
Yeah.
about America because I had a son that needed Accutane, and we were on, like, um, private insurance at the time, like, our own insurance. My husband owned his own business at the time, and it was $500 a month, and that was a hard pill to swallow, but I'm like, "My teen doesn't wanna go outside." But then when we swapped somewhere in between the 18 months or I don't know how long he was on it, but another one was $5 a month, just like a main provider insurance, and I was like, "This is like, there should not be that discrepancy of 500 and for any medication." Like, w I don't know. It really is
It is
frustrating.
very frustrating. It is very frustrating. And so you have people, and then we like there's Canadian pharmacies that they can patients get it for about $300 a month, with a from a U.S. prescription.
Well,
So you need
that's
the U.S.
helpful
prescription.
then.
Yes,
Wow,
it is.
Yeah. Do
wow.
you think there'll be a shortage again since it's like such a big medication?
There are small shortages of certain doses from time to time, but I feel like the production, Eli Lilly is doing the best. They're building factories as we speak to be able to supply, but it's just that demand is so great, right?
Yeah.
Worldwide.
Yeah. Well, I know I was in Australia the first of the year, and they were all sold out. Well, as the strength and conditioning coaches were saying, because all the bodybuilders were, like, hogging it
Nuh-uh.
from everyone, which is terrible. I mean, it's, like, I don't know if there's a shortage now, but I know that they were like, again, there were 2 sides to the story, but down there, it's very different, obviously, than here as well.
Yeah.
every country has their own kind of issues and things, but we've got to get the insurance part figured
Yes,
out
we
here
do.
in
Yes, we
America
do.
for
Even
sure.
for
So
patients and for doctors, honestly,
Yeah.
it
yeah,
hurts both
I
sides.
mean, I ended up having a knee surgery, a major knee surgery at HSS in New York. And one of the top physicians that there were like two that did this specific knee surgery on women over 40 because it's a terrible success rate. And the doctor's like, "Well, here's my price. I'm out of pocket." And I was like, "Take my money." I was I mean, I was so desperate because 'cause I'd been a year with just, like, nothing, but I get why physicians are just like, "I'm not working with this anymore.
Yeah, I
It's a
don't have insurance
circus."
in my office,
Mm,
but this is the only
so
way I can
frustrating.
spend 1 hour with my patients, right? And
Yeah.
when
Yeah.
you're talking to someone with obesity that they've struggled through childhood and they're in adult life, you cannot have this conversation in 15 minutes. You cannot
No.
open to anybody in 15 minutes. You cannot earn a trust and build a relationship with a 15-minute appointment, right?
No. No.
I'm in love with you, and
Same.
I'm like,
I'm like,
"You
I
need to be
can't.
in."
Let's plan a trip to New York, Kaylee.
Ah,
Yes, I know. We're going to New York, and I mean, I just think of all of these people that have reached out to me that like, I mean, they need you on speed dial. I don't even know if are you taking new patients?
yes, I am. I
Do
take
you
new.
do
Yeah.
Zoom? Like, so for people that don't live in New York,
Yes, I do telemedicine. I have patients all over the world, and
You're about to not be accepting new
I
patients
know.
because everyone is gonna be obsessed and, like, coming to you. You're like, "Get
Exactly.
on the wait list for a year."
no, I'm working very hard so I can accept. I cannot see everybody. I
Yeah,
accepted that, and I can't,
Yeah,
but I'm trying to see as much as I can.
I love
I do
that.
too.
Well, okay, so before we close, and this is something that we should have talked about at the very first, but I've just been so it's been so fascinating this entire conversation. Can you explain for people I feel like everyone knows about these drugs now, especially from like Oprah, has talked about it a lot and obviously a lot of big people on social media, but for someone that's like, "Oh, okay, I know that this is a weight loss drug, but what is it actually doing to help me lose weight?" For people that don't understand that part.
So the pharmacology of this drug is they're synthetic hormones. We make this hormone GLP-1 in our small gut. And what they do, we have receptors for this hormone all over our body. But in regards to weight loss, what they do is in our gut, in our stomach, uh, we have receptors that when we have this medication, when we take this medication, when this hormone is there, it increases our satiety hormone. So it activates our satiety. So when you start eating, it activates your satiety signals and you get fuller with smaller portions of food. And then in between meals, it suppresses your hunger hormones. So when you feel hungry, you eat small portion, you get physically full and satisfied, and then you're not hungry for a few hours. Then you get hungry again, but then you eat a small normal portion, right? And then in our brain, in the hedonistic eating and drinking area where we eat for our reward, for
Mhm.
pleasure, anxiety, boredom, um, it takes away any anticipation of our reward from food or alcohol. So if you think about it, let's say a glass of wine. Whenever we think, oh, I'm going to have a glass of wine at night, you're anticipating, I'm going to feel relaxed. I'm going to feel this. I'm going to be in a social setting. It takes away that anticipation. You reach for it and it doesn't give you that back anymore and the behavior changes. Same with foods of some patients that eat boredom or anxiety at night or binge at night. It's because you're seeking some sort of relief or some sort of reward. It takes it away. You still enjoy your food when you're eating and you're hungry, but when you're physically content, you don't think of food anymore besides as food when you're hungry. So
That's
that's what that noise that people say that
yeah.
stops is because you're not, you don't, and then it's not like you don't have anything else to look for, because many patients said, well, food is my pleasure, is you replace it for something else. Many
Mhm.
patients replace it with exercising, anything else, then it's not going to be food, and for some, many alcohol. which is another great thing with these
Yeah.
medications, is that it cuts so much
Yes.
There are
patients.
so many benefits. Okay, so if a patient is on this long term, do they usually have to stay at the same dose, or do you have to increase it or decrease it because
So
of the
to get,
longevity?
depending how much weight we're talking about,
Mhm.
right? I mean, I've had patients, the one that lost the most is 170 pounds.
Wow.
So they work, I mean, when they work great. Um, but to get to, let's say, to that goal, or to 30, 40 pounds, we may use higher doses to get
Right.
there. But once we're there, when we're in maintenance, that we're not looking for any more weight loss, I cut back on the doses. And this slowly, as slowly we went up, slowly we will go down,
Yeah.
because we're not looking for more weight loss. The patient can be eating a little bit more for
Mhm.
maintenance.
That makes sense.
Oh,
I cannot believe the behavior, psychological changes, all the benefits that come from this drug.
I've had grown men cry in my office that for the
Oh,
first time they feel
yeah.
relief.
Yeah.
that's
Okay. So wrapping up, Laura, do you have any other questions?
no, I feel like you explain this so well, and I don't know, this has been such an exciting conversation.
Thing.
Yeah, a much needed
Yes, much
conversation too.
needed.
S- So to kind of wrap up, and you have mentioned this now multiple times in this interview, the biggest thing about the weight loss, I mean, I'm just zoning out on one portion, but the muscle mass is so imperative to keep for a myriad of reasons. But mainly, if we're looking at like, we don't want the resting metabolic rate to go down from the loss of muscle, especially these perimenopause, postmenopause pausal women. So that has to be the priority, the high protein, the strength training, along with something like this for those who need it. That's like the magic
That's the
pill.
trifecta, yeah.
And
Yes.
even that I didn't mention this, but what I see in my body compositions in my patients is that when they lose muscle mass, they could be in one, they could be in two weight loss medications. They might have lost 10 pounds. If they lose muscle mass, their percentage body fat may go up, even
Yes.
though they lost weight, right?
Yep.
So, muscle is so imperative for the proper benefit or the maximum benefit of the medication. And when patients see this, when they see that they lost muscle and they gain percentage body fat, it switches completely, right? They get
Yeah.
why it matters so much. So I really think we should focus more on muscle gain or preserving muscle than weight loss or fat loss. Because if we concentrate on the muscle,
Mhm.
preserving the muscle or muscle gain, the fat loss is happening. To
Yes.
maximize the benefits of these drugs, you need to have the conversation about muscle.
Mhm. There it is,
I mean,
folks.
mic drop.
Mic drop. Nothing else needs to be said. Okay, Dr. Whalen, thank you so much for joining us. I appreciate your time. I know you're on spring break with your kids, taking time away. So we are so grateful. I cannot wait for this episode to
Me
air.
too.
So thank you so much for joining
Thank you for
us.
inviting me.
Yeah,
I
means the
really
world.
enjoy this. We should do it again, talking about
Yes.
exclusively perimenopause and menopause women. I think we should.
Yes, let's do it. That's round two.
We deserve a full podcast just for them.
Oh, yes. Okay, we're doing it. Well, until next time. Thanks for listening, everyone.
If you enjoyed this episode, please consider giving us a 5-star rating and sharing the Body Pod with your friends.
Until next time.